with a recap of day 1, highlighting the key learning points and take-home message from yesterday's enlightening discussion.
The session was done by Dr. Gopanna CA, who included documentation in emergency medicine practice. He told us about the importance of consent, and the key home message was in setting of emergency, if you don't write, that means you did not do it. That's what he meant to say in the sessions.
Is how essential medico-legal awareness is in emergency care. Now we move on to one of the most dynamic and thought-provoking sessions of today, the panel discussion. This segment brings together experts from multiple specialties to discuss the real-life challenges in medico-legal and emergency care.
Our distinguished panelists are Dr. Dev Lakshmish, Dr. Shyam Aparna, Dr. Prashant CR, Dr. Chetan, Dr. Apurva Prasanna, Dr. Shrikant HJ, Dr. Chandrasekhar, Dr. Shruti, and Dr. Sumukh AT.
Medical department in KODAGU Medical College is doing extremely well. Trauma cases they are handling, and a lot of cold cases also they are doing, congenital anomalies and trauma cases, especially joint replacement. His passion and his department is doing extremely well in KODAGU, almost on par with any other medical college. They are doing a lot of work, academic research and all they are doing in the department of orthopedics. And we have Dr. Chandrasekhar, who is general surgeon, assistant professor in general surgery. He is basically a laparoscopic surgery. I worked with him in KVG Medical College, Sullia. He was my colleague there. Now he has joined, myself also I have joined KODAGU Medical College, as well as Chandrasekhar. Dr. Chandrasekhar is also a faculty as assistant professor in Department of General Surgery. Yeah, Dr. Sumukh, she is our casualty medical officer. She has got a vast experience in casualty handling the emergencies.
Panel discussion, we have a theme as miss no clues, do no harm. So generally, this is a panel discussion. It's slightly different from the general what academic panel discussions we do on other conferences. What we generally tell is do no harm. So if a patient is lying on the floor, what after a road traffic accident, first aid and they'll go and give water to the patient. Actually, many patients will die because of that water. They'll aspirate, the water will go to the lungs. The patient will die. You think that the patient had accident, he died. No, you killed the patient. You made him drink water and the water went there. He died of asphyxiation because of water. So just the general theme of first aid is do no harm. If you don't know what to do, don't do anything. If you are doing something what you don't know, you are going to do more harm than benefit. So in emergency medicine, you are not supposed to miss certain clues. Face the patient on face. So the first question will be a general question, if not be an academic or a subject-wise question. How do they deal with such scenarios? What problems they face in such scenarios? Next, the question will go to the specialist proper. So they will tell us what better can be done. Okay. So 32-year-old male, previously healthy, wearing a helmet, is brought to emergency department after high-speed motorcycle collision with a truck. He was a helmeted driver. He was thrown for around 10 meters. Brief loss of consciousness for 1 to 2 minutes, immobilized and transported within 20 minutes. So this is one of the commonest road traffic accidents we see. At least here he was putting a helmet. Most of the time what we are seeing is non-helmeted, thrown away, brought. Okay.
Then airways to stabilize him, and then for chest trauma we give a call to surgeon, and also we'll stabilize the neck in meanwhile. And then after that there's an active bleeding in the left femur, so he is in hypovolemic shock. So we'll access IV lines and we'll go with the fluids, and also we'll ask for an orthopedician to come immediately. So that's how we'll manage.
Cold peripheries, that means that it's going for hypotension. Pelvis is unstable. Unstable, if you are trying to cover, there's a test called compression test. If you are pressing the pelvis from both sides, it should be stable. If it is wobbling, that means that the pelvis is unstable, there's a fracture there. There's active bleeding from the thigh left womb. Disability, how we are going to estimate disability? Pupils are equal and reactive, that means the brain is almost okay. No lateralizing signs. Lateralizing signs, there are 2 arms. If you tell the patient to lift the right arm, he has to lift. If you tell him to raise the left arm, he has to lift. If he is not lifting one of the arm or one of the leg, that means that he might have blood inside, a weakness of that side, fracture of that side, or a stroke in that side. Exposure, after exposing the patient, you have to see what is there in the whole body. You have to literally make him naked. That is the actual protocol, but most of the people, they don't do it. There is a open it. You want a trolley, or the patient can walk in, or you want a stretcher. So one day, we had just finished the seminar and I was standing outside. One small ambulance came, and the front person, her name is Niranjani, she just went to ambulance, she just opened this one, and it was a very mangled body, very badly pressed. As soon as the stretcher came up, she started screaming. They can honor. One is assessment, another one is imaging. So what is the role of imaging in emergency is very important. So what are the internal bleeds? What are the external bleeds? External bleed you can see. There are a lot of internal bleeds which you cannot miss. So Dr. Shyam sir, what is the role of imaging? For example, the E-fast, pan CT. There is a concept in private corporate hospitals, pan CT. As soon as a patient comes in trauma, send the entire patient into the CT machine. That goes against the ethics of emergency medicine as a subject. If both body CTs cost in a corporate hospital go up to 20-25,000.
E-fast no doubt plays a very important role, and what we mean by E-fast is you use sonography as an assisted mode in trauma, and when this happens, the most important thing is we need to know whether there is internal bleeding or not, and E-fast gives you an immediate assessment whether there is internal bleeding or not. And in E-fast extended, when you have in normal regular cases, you use what is known as the fast. That's when you only use the lower abdomen to assess if there's a problem. But when it comes to E-fast, you also take the upper, the extended area is the chest, where you want to rule out pneumothorax and where you want to make sure that there's no hemoperitoneum and at the same hemothorax, sorry. And then the other one is whether there is any other pleural effusion or things like this. So these help you assess where exactly and how exactly there's a certain problem and how you can take it to the first step.
Left quadrant, suprapubic region, epigastric. So what we are keeping a focus on, just seeing whether there is a bleed or not. And CT as provision, we cannot push a patient who is in hypotension into CT scan. Most of the time we send a PG, when we are sending a patient to CT scan, we'll be sending a postgraduate student along with intubation kit, because he might arrest in the CT room, or on the way to the CT room the patient can have a cardiac arrest. We used to go to on the way, as a postgraduate we used to go, we have to intubate on the way. Basically NMC says that the CT room should be within a certain distance from the emergency room. That is one of the NMC requisition to get a NMC guidelines to get a permission to run a college. So most of the college, whereas in JJM the CT room was almost half a kilometer away from the emergency room. We had to push the patient, go. It was like a picnic for us. Go there, on the way, go have a coffee and come back. Okay, so, but there is one problem with the
Inspection and Monitoring Committee at PCP in KODAGU district. I have faced as a person to do in casualty boring, and also we have answered because we have done it very well, having 12 missions given permission, including OT, ICU, everywhere, including casualty, quite right now. We only have given from KODAGU district authority 12 missions given. I don't know what happened in KVG, maybe related to Mangalore district DHO officer. The point is, PCPNDT says detection possible potential mission should be avoided for sex determination. That is the main point of PCPNDT Act 1994 and Rule 1996. In Rule number 3B1 of 1996 says, these portable missions are prohibited now. Earlier there used to be a mission that carries to many centers, so one person used to do, but that has been banned now.
What we have come across with this act is, it's an act which has come into force without consultance of the doctors. That's the actual problem. What the act does not respond is, the only thing that the act thinks of is every doctor, whoever's a radiologist, whoever's doing a scan is only interested in sex determination and nothing else. Unfortunately, that's not the truth. They never have actually looked into situations like recently they've also come out with a thing saying that not more than, a radiologist can't visit more than 2 centers. Totally obnoxious this one. The reason why I say this is, now take a place like Cook. The same act says that has a radio. We don't have radio on this.
Partially true, sir. Myself and Dr. Anand had an opportunity to visit one of the conferences which was done at Hassan. The BCPDT usually every year they will do in districts. So it will be on a rotation basis in a district wise. So there almost some 150 to 200% delegates were attended the particular conference. There we had, during the lunch break, we happened to interact with many of the stakeholders who had attended the conference. The particular person, I just don't want to name the person, the female was from KODAGU itself. And we were discussing with respect to the PCPNT and sex determination, all those things. And it's horrifying to listen that even in our KODAGU district itself, and some of the neighboring districts itself, some of the district sex determination is happening there, she said.
He was dehydrated. So we wanted to give fluid challenge.
The management of the trauma case, especially in the polytrauma setting, it begins from the time zero. The time zero means that before, just a second or fraction of second before the injury happens. So we need to make sure that the mechanism of the injury, patient factor, and the goes on. As you all know, the triad of death: hypercoagulability, hypoxia, and hypothermia. When it sets in, there is a mortality rate increases and exponentially. It increases more than 40%. So how not to miss? So as per the mechanism of injury, you can see the obvious injuries like external hemorrhages, fracture, bleeding from sides, okay, in airway obstruction, and like that. These are the obvious signs which can be seen, but there are occult signs which cannot be seen. So you should be knowing about, for example, the same patient who is thrown out of the bike, if we have fall down on left side.
Not fatal immediately, but these are the potential source of the hemorrhage and inflator in human. These are the potential source of the bleeding which will lead to the hemorrhagic shock. The idea is to first stabilize the major source of the bleeding in the arthro injuries are the pelvic injuries. Usually it can bleed around 4 to 5 liters. Okay. And most these bleeds are the hypotensive bleeds are the low pressure bleeds.
Guided procedures and fast, majorly fast. So we used to do ourselves fast. We don't give report. That is for us to diagnosis. Hemoperitoneum is there and hemodynamically unstable patient. We'll immediately rush to the OT with the resuscitation with the massive transfusion protocol. 1:1:1. One PRBC, one platelets and one FFP. We used to take him to OT and we used to open. Here comes our concept called as damage control surgery.
The basic principles will be golden hour. The first 1 hour is the golden hour. In that, airway, manages airway, manages breathing, intubate him if he is not able to intubate. Circulation, take care of his circulation. Rest everything has got time. Even if you mismanage certain other things, disability, exposure, you have got time. Experts can come, others can come, you can refer, you can reach somewhere safely. But within 1 hour, if you are not managing your airway, breathing and circulation, you are going to lose the patient. So with this, going to the second topic, second case. So this is a real case which one of the physicians had come across. It's a tribal male from Badale, 25-year-old, beaten by a snake at around 2 p.m. Presented to ER 2 p.m. He was taken to the Badale hospital, to PHC. Badale, doctors have come. Patient was initially treated in the Badale PHC. 1 vial of ASV was given and referred to higher center. Okay, en route to hospital, patient developed vomiting which contained fresh blood, clots and gum bleeding.
Physiologically, patient is improved. Later, when the physiology is favorable, then taken into the definitive procedure. To say, for example, in a liver injury, the only thing we do, or any liver injury, the only thing we do is packing and keeping the packing on compressing, or in major vessel injury, we will tie and we will just to achieve hemostasis. And then to coming over to the fracture here, thigh, it has to be splintage, because in the pelvic fracture and the thigh femur fracture, the loss of bleed will be higher. And coming to the last question, where the chest, abdomen or pelvis, which has to be given more preference. The obvious we have to breathe. That means the chest comes the first. The next, the pelvis, which is a huge container. It's a bucket. It can collect more amount of blood. So, and it can be managed simple by putting a external pelvic binder.
Is when the patient comes, they usually tribal patients, they get the snake along. So that is what we have seen. And once we had a time when the snake was not even dead. They got the live snake and it happened to crawl in the casualty. And then we had to call the people and get the snake again back into the sack where they got it. And here in cases, the presentation is mainly, if it is a tribal patient, I have seen the patients, they tie anything which they get very tightly over the wound and get the presentation. I don't think that has to be done anymore. The tourniquet is contraindicated. And as soon as the patient comes, even if it's a tribal patient, they will squeeze, they will cut the wound side, they squeeze blood out of it and get the patients to the casualty, which I think causes more harm than help. And what we do here is basically, we draw the whole blood clotting time. We draw the blood for the whole blood clotting time, especially in the glass slide we prefer. And then here I don't think 1 ASV would help because we have seen neurotoxic and hemotoxic cases usually. Neurotoxic, the presentation is mainly there will be drooping of eyelids and all the neurological symptoms. But in hemotoxic, the patient will have, the localized will be, there will be a specialized fan mark will be there. Pain and swelling the localized areas, which we have.
Okay. See this, that snakes which affects the nervous system, they cause very painful bites. Especially these cobra bites, crate bites, they are very painful because they affect the nerves. And within 5 to 10 minutes, if it is not treated, they don't get a ventilator, they will die. Within half an hour to 1 hour, they need a ventilator. They have to be intubated. So God has made such a way that cobra bites are painful that you check what has bitten you. Okay. Whereas these viper bites, usually the viper bites are at night. Usually in the village, where people sleep on the floor, the vipers come in, they bite, especially the kids. They don't even know that it has bitten. Just like a prick. Some people they think that it is rat has bitten the babies, but it will be a viper bite and viper.
Toxic bites, ptosis and double vision may be the initial presenting features, and both ptosis and ophthalmoplegia will automatically improve with administration of ASP. But some cases in neurotoxic bites, they may have prolonged facial palsy, which may cause the patient to have an exposure keratopathy. So we have to manage it supportively with lubricants and sometimes patching the eye at night. And in rare cases, we may also do a tarsorrhaphy. But in case of hemotoxic bites, patient may present with sudden loss of vision because of vitreous hemorrhage or hyphema. Retinal hemorrhages are
Subconjunctival hemorrhage.
Yeah, it can be a subconjunctival hemorrhage as well.
Painless actually. Crate bite are painless, not the viper bites. Probably viper bite is painful. And most of the times the crate bites, it happens in the night. Okay, it happens in the night. Majority of the rural people or village people, they usually lie on the floor. And what they say is, usually the crate will pass the room in the corners of the room. It will never go in between the rooms, okay? So they say that you are not supposed to sleep on the corners of the room where the crates, usually the traverses and these things. And night times, as you know, since it's a painless bite,
whether there's any bleeding inside. Then the other thing is, of course, a few other things also where ultrasound plays a role. That's if you take the Doppler component of it and if the patient's leg is completely swollen, then of course it helps you assess. Then even if you have to decide whether because of a compartmental syndrome, this one, whether there is, you want to go ahead with the faciotomy, again ultrasound will help you.
Maximum dose of ASP, that is 24 to 30 vials. Post ASP transfusion, the bleeding stopped, patient stabilized, and he had lost a lot of blood. Then later we managed to get blood products from MADIKERI transfused. He was discharged home, so without any complication. So basically, when you manage snake bite, you need to categorize the patient into 4 groups. First group would be vasculotoxic, which is seen in Russell's viper bite. So vasculotoxic cases present with bleeding from gums, upper GI bleeding, lower GI bleeding, DIC or acute kidney injury, hypertension and shock. So such patients, the first thing is to stabilize the circulation by giving crystalloids. and start the patient immediately on ASV. That is 10.
Snake bite is assurance. And I don't know how far the data is true. People say that 90% of the snake bites are dry bites. Because all snakes are nocturnal. If you see a snake roaming around in the daytime, that means that it didn't have a meal night or it has been disturbed from its resting place in the day. That is why it is moving around. Generally, snakes are nocturnal. At night, if it had a meal, it has eaten a rat, most of the time its venom is almost over. Early morning bites, it's almost a dry bite. So 90% of the snake bites are considered as dry bite. Data has to be checked.
Stop this therapies when the patient starts developing bradycardia and respirations. That is the side effects of neostigmine. So in crate bite, problem with crate bite is that patient won't have any fang mark. Patient might present to ER with complete locked-in syndrome, that is quadriparesis, oculomotor palsy, diplopia, nothing. Patient won't have any history of snake bite. It will be just patient has slept in the night, morning the patient is not waking up. So in our areas we have to suspect crate bite in such cases.
It just blocks the lymphatic flow, not the blood flow. Okay, no cutting anything. Reassurance is the first thing, and if at all, don't keep the limb elevated. Keep it in a dependent position so that it doesn't putting the limb up. Generally, if the patient is hypotensive, they are told to keep the foot elevated. Just keep the side. Don't put anything. Won't put detergent. Bring him into the hospital is the first thing. That is why the tissue is reacting to it. So next, you tell that person to tell 1, 2, 3 per second up to 20 minute breath hold. Some people will be uneducated, they know 1, 2, 3 ಗೊತ್ತಿರಲ್ಲ. They can say 1, 2, 1, 2. In one breath, if they are able to tell 20 digits, that means that their breath capacity is good and still the snake has not hit the nerves. Sometimes you can, vibhuti, kumkum, whatever, again, case here. Okay, yes, it has to be completed. So case 3, this is a case of breathlessness. So this is one of the commonest types of emergency that comes to the emergency. My wife being a pulmonologist, she keeps telling me that all breathless patients, they give me a call, so I put this case. So
anxiety cases among females and students, we get anxiety cases like hyperventilation will come there. And also many of the cases will be of infection, followed by some infection. And sometimes we have to differentiate between cardiac and respiratory cases of breathlessness. So we go with the saturation, like how if the patient is stable, we'll go with the saturation and we stabilize him with giving oxygen or nebulization required or any steroids. If it's a cardiac patient, we go with the ECG, and if there any requirement like pulmonary edema and all, we took give the classes and will inform concerned departments.
Cases like pulmonary embolism. So Dr. Dev, when a patient with breathlessness comes, what are the clues that tell that we should not miss the case of pulmonary embolism?
You mostly sinus tachycardia. ECG is Swan Q3 T3 is very uncommon, although classic. Secondly, the blood gas, it may be hypoxic but mostly hypocarbic. And thereafter, typically clinical symptom wise, of course, there might be ranging from mild symptoms of chest pain to slight pain during inspiration to hemoptysis, or for that matter, frank shock.
What you need to consider before you go in for pulmonary angio CT is the D-dimer. If the D-dimer comes positive, then of course it's a gold standard that you go in for, and the pulmonary CT angio is the gold standard for detecting embolism.
He came with breathlessness while walking. She had seen the case and sent it to get echoed. It was sent to the medicine OPD. There the patient got irritated that interns are seeing me. So he left the place. He was an employee of DCC Bank. So he came, next day he came to the DCC Bank morning, he works in Virajpur. He walked into the DCC Bank, he felt breathless, so he came to our center. So initially he was telling breathless, and when I walk, I get breathless. Then my friend had brought me actually, and he said, sir, bala tension, his daughter is getting married, marital life is not so great, maybe. And I also attributed mostly it is that only. Because
left heart failure. And third one will be life-threatening arrhythmias. So other than the cardiac problem, we can think of acute onset breathlessness could be because of other metabolic causes, metabolic acidosis like DK, diabetic ketosis, lactic acidosis, or acute kidney injury.
Always keep a suspicion of MI. Any patient who comes with a pain which is starting from the line, if you draw from the lobe of the right ear till the left anti-iliac spine, if you draw a line, anything beside it can be MI. You had a patient who had pain only in this part, left side of the jaw, it was a MI. Okay, so never miss an MI, and all patients, irrespective of age, sex and gender, when they come for chest pain, you have to advise.
Never miss MI. Because you have seen so many cases where the patient has got a normal ECG, normal cardiac enzymes, normal echo, normal T20, even then the patient has got critical blockage. So,
and his D-dimer is normal. So does that rule out that it is not a case of pulmonary embolism?
As per studies, yes.
CVAP, that is a classification of varicose veins. So that may be false positively giving D-dimer. D-dimer can be false positive in varicose veins. So I have classified the varicose veins class also in the diagnosis. C5CAP. Query.
Troponin which is negative, that doesn't rule out MI. D-dimer being the negative, the timing is very crucial. And secondly, pro-BNP is a very useful test which we all use, like, because most of the breathlessness is either respiratory or cardiac. So you do a pro-BNP levels. If the pro-BNP levels are very high, you can possibly think it is more of a cardiac cause, and the pro-BNP, if it is slightly on the lesser side, it goes in favor of pulmonary. So we used to use this in trial.
2 points, intermediate is 2 to 6, high risk is more than 6. So more than 6 it comes, it is pulmonary. So scoring has to be used. Or else D-dimer. D-dimer is the diagnosis. When D-dimer is low, probability of it is being pulmonary is very high. Come to the fourth case, but you should not miss such cases. So, sir, what is your take on it?
Proved otherwise. There could be other differential diagnosis, but most CRAs are either precursors of a much more catastrophic cerebral stroke. So the goal of treatment or the goal of identifying the particular stroke would be to identify the site and cause of the block, and to prevent much more larger cerebrovascular stroke or the similar event in the EL negative. It is almost 100% that it is CRAO. If it is slightly better, then check the pupillary reaction. If you have RAPT, it is again CRAO.
What is the role of CT imaging in such cases till you come in?
CT has a very vital role.
Or MRI?
Yeah, CT
Should
MRI.
we call for a CT or MRI?
Both, sir.
So at the meantime, we have to coordinate with the anesthetist and the nursing staff to get ready for surgical interventions. So if the cardiac arrest occurs before reaching that emergency, so we have to do CPR as per ACLS guidelines. So this is a case of cannot intubate, cannot ventilate. So in that case, we have to do cricothyrotomy. That is the emergency procedure. That's the simple and fast entering into the airway.
And managed by high flow nasal oxygen. So more and more of high flow nasal oxygen that ICUs and hospitals could involve. The acute airway catastrophes can be
HFNO can be used in such situations before the definitive help comes.
Yes. Before the definitive help comes, and even thereafter, it does, because even a narrow airway, the high flow nasal oxygen is able to hold that narrow airway and cause adequate oxygenation.
In the screening, they screen out for pulmonary embolism.
Dr. Shah.
Sir. That's good.
Dr. Shrikant. Dr. Sumukh Eti. Dr.
Jodi in the Department of Forensic Medicine and Toxicology, KVG Medical College, Surya.
Bad because we had completely neglected that aspect. So I would thank Mohan Apaji sir for conducting this beautiful session, and I will hand over the mic to my co-chairperson Surya Kumar sir for introducing Dr. Joga.
Actually, sorry to start with this. I just want to tell you that in that particular case, I was issued a summon. I had gone to Bangalore. I went to the court, but the judge was on leave on that day. So I took the attendance certificate, came back. But later on, I received a non-bailable warrant, NBW. Why? The reason was revealed to me after going to the court. Because, sorry to say this, sir, the public prosecutor was retiring on that particular day. It was a case of murder. Somehow, he wanted to get me on the witness box and make me utter some silly things so that the case will be over then. That is why the non-bailable warrant was issued.
Argue and make presentation of sufficient. Now we are doing it before this august presence of doctors or budding doctors. Opportunity is very, very invaluable, and I am really thankful to our professors. Almost 3 or 4 months back, they have moved the idea, and accordingly, each day they were inquiring about what kind of infrastructure, what kind of preparations. I felt very, very happy. No, they are all facts, the kind of your experiences, and I must tell you, person representing the legal profession, I am not surprised. The kind of insensibility, the kind of institutional insensibility is writ large in our legal profession and judiciary. I think that is the reason why we always feel what we need to do is to recognize the dignity in an individual, the kind of service you do to the community. It's not what deposition you give, that is immaterial. If you are standing in the court hours together, what happens to your patients? I think that's where it is necessary that we need to be much more, and I am sure over a period of time, but I really apologize for the kind of...
Professor Dr. S.V. Jogarao, his qualification is LLB, but he has additional fellowships mentioned in British Medical Council and Max Planck fellowships. His present designation is Founder, Senior Advocate, and he is Healthcare Consultant and Legal Excel Attorneys, Bangalore.
Not from medical perspective, but from legal perspective. Okay? And the second one is a problem on medical negligence. Purposefully, we have not distributed or shared the problems with you, so that your attention will be on the court representation. That is the one reason. Secondly, before we commence the proceedings, I just want to make it very clear. I know that it's being recorded and our friend is very seriously recorded. Therefore, I need to make it clear. This particular exercise is only to disseminate information and for educational purposes. Not to derogate, not to defame, not to mimic anybody, either from community of judges or judiciary or lawyers. It is purely academic. With our own experiences, I am sure there may be here and there some kind of breach of standard, etc., for which we definitely seek your apologies. But having said, we wanted to present, I told Dr. Kedarnath, it should not be like a Bollywood movie.
Banastwadi Police Station versus Anthony Raj. Advocate Dr. S.V. Jogarao.
Your Honor, of late in our society, we started experiencing social media abuse and misuse. This particular private complaint is against 3 individuals who have not merely forwarded the message, but they are the authors of the message. If we go through the message, it is so clear that defamatory, derogatory, and with character assassination of a celebrity figure of Karnataka state. It is not only those who their posts have literally created such a kind of viral, and I must tell you, it is celebrities, family members also have been indicted. Therefore, I am of the opinion, in response to the complaint, notice may be issued to all the 3 arrested.
Issue notice returnable within 3 weeks.
(24/1/26). SC 281 of 2024, State of Aryavarta versus Akasha. Dr. S.V. Jogara, Advocate Arun Kumar, Advocate Kavana.
We are for the accused methods. So, I will just briefly address you with the facts of the case. The accused is a 19-year-old boy and the victim is a 17-year-old girl. They have had a consensual relationship, but the accused has been arrested on the case of POCSO, and the victim parents have been put him before the bars for the case of POCSO methods. So I am filing under section 439 of BNSS 2023, we'll be filing a regular bail application methods today, and this is the brief of the case, and this is the application that we are filing.
Since how many days he is in the prison?
He is behind the bars for the past 4 months, my lords.
Will hear.
Please, my lords.
Yes, please proceed.
I request prosecution.
Any objections?
I share with you what I think about the proposed bail application. I just want to bring it to the notice of this honorable court. In the last 4 to 6 months, there were multiple decisions by Honorable Supreme Court of India on the subject matter called adolescent love. I may also further bring it to your kind notice, Your Honor. The Supreme Court appointed senior counsel Srimati Indira Jaising and appointed as an amicus curiae on a particular petition because there were very concerning interpretations and judgments wherein Honorable Supreme Court consistently held that even though technically the victim is a minor, I repeat, even though technically the victim is a minor because she may be 17 or 17 and a half years, POCSO is attracted. But the adolescent love, which is the underlying factor, needs to be taken into consideration. And accordingly, no doubt the present dispensation, the central government through Solicitor General made it very clear that they are not interested in reducing the age of the minority insofar as POCSO is concerned. That stand is very clear. However, Supreme Court did take note of the relationship, which my defense counsel very rightly pointed out. It's a consensual, that's what she said. In my opinion, it cannot be consensual because a minor cannot give a legal valid consent. But having said, Honorable Supreme Court, the way they have interpreted, as as matters stand, till the government of India takes a thing, I am not going to seriously object to the bail application preferred by the defense counsel.
We'll post it for order in the afternoon.
Please, ma'am.
Much obliged. CC 123 of 2025, State of Aryavarta versus Mr. Raghav Sharma. Advocate Dr. S.V. Jogarao, Advocate Arun Kumar, Advocate Kavana. Representing the state of Aryavarta, Your Lordship, this particular case revolves around the charge under offence of murder, section 103 of Bharatiya Nyaya Sanhita 2023. The accused has strangulated a 7-year-old girl and accordingly she died. Thereafter, the police investigation quite clearly revealed that he was the last person who was in contact with the girl before she died. And on the basis of which the investigation revealed that with due certain attendant circumstances, he was the gross suspect. And accordingly he was arrested and bail petition has been rejected. Your Honor, the point here is, as per the statement given by him, they wanted to invoke unsoundness of mind or insanity as the defense. Therefore, on one hand, the burden of proof on the part of prosecution to prove beyond reasonable doubt that the accused has committed the offence of murder, to precisely point out section 101 clause 3 and punishment under section 101. However, they would want to invoke the defense of insanity, that is section 22 of Bharatiya Nyaya Sanhita. This is a thing.
Mr. Defense Counsel, have you introduced any evidence in this regard to prove the insanity?
Yes, my lords. So as the counsel for the state of Aryavarta has already briefed you with the facts, and he has told you the section we have invoked is section 22 of BNS of 2023, and we are seeking the defense of insanity or unsoundness of mind. So in order to prove our contention, we file the evidence affidavit to the Honorable Court.
Any cross-examination?
Your Honor, before I delve into cross-examination, I would want to submit the current position of the law. Because it is a very serious charge, the most stringent punishment, and the most complex defense in the form of insanity. I think a comprehensive understanding about the substantive and evidentiary legal aspect, to my mind, is necessary. If the permission is granted, I would want to cover the fundamental current position of law.
Please proceed.
Your Honor, to begin with, I want to make a mention. Indian Penal Code served us for so many years. In the year 2023, it was substituted or replaced by Bharatiya Nyaya Sanhita 2023. Now, if we look into speaking for the context of this particular case, murder charge, insanity defense, BNS is no different from IPC. In fact, BNS left untouched the framework governing culpable homicide amounting to murder, culpable homicide not amounting to murder. The entire framework has not been changed. Similarly, vis-a-vis general exceptions, the framework and particularly insanity, if you read the provision section 84 and section 22 of current BNS, the same section. Why am I presenting this? Your Honor, this is necessary because Even though BNS has come into being as a revised criminal law, the content of Indian Penal Code continues to be relevant because of no amendment is. As a result, the most significant thing which I think we need to appreciate in terms of judicial precedents, the judgments which revolved around interpretation of Indian Penal Code provision, which left unamended in BNS, continue to be relevant. That is the precise reason why, Your Honor, we need to know the current position of law. There is every possibility, people who are not aware about IPC, they may think it is a new law. No, it is not new. Particularly Section 22 and Section 101. Therefore, to begin with, while emphasizing on that, Your Honor, I draw your attention to Section 3 of BNS 202. Section 3 deals with general explanations. It reads as follows. Throughout this Samhita, every definition of an offence, every penal provision, and every illustration of every such definition or penal provision shall be understood subject to the exceptions contained in the chapter entitled General Exceptions. Though these exceptions are not repeated in such a definition, penal provision or illustration. To my mind, particularly the problem revolving around murder and a general exception like insanity, Section 3 is the most important provision. Which means, whenever an offence is to be interpreted, the offence is to be interpreted in the context of general exception. To that effect, I would want to present one more important information. Is there a difference between a general exception and a statutory exception? Your Honor, general exception, if there is proof, it leads to exoneration of the charge of the accused, which means he is acquitted. He is absolutely. But when it comes to statutory exception, it does not deal with the exoneration, but it only deals with diminishing of the nature of the offence and diminishing of the nature of the punishment. To that effect, the best possible example, grave and sudden provocation, under Section 101 exception.
Mr. Prosecutor, can you distinguish or clarify about the general exceptions and statutory exceptions insofar as insanity, defense of insanity is concerned?
1. Grave and sudden provocation, exceeding right of private defense, sudden fight, consent, these kind. But insanity we don't find. Which means there is nothing like insanity as a general exception and insanity as a statutory exception. The same thing is not applicable to RPD. Right of private defense is a general exception. But right of private defense is also a statutory exception. I think that is one thing we need to take into consideration. Therefore, if the defense wants to invoke unsoundness of mind under Section 22,
it shall be truth, the whole truth, and nothing but the truth.
Good afternoon.
Good afternoon.
Dr. Arun Mehta, you are from which part of Gujarat?
I am from Ahmedabad.
I'm told you have completed almost MBA. Yes. Now, friends, every one of you. Yes, doctor. Now, what I want to know is, you know Raghav Sharma?
Yes.
Have you treated him?
Yes.
When?
About a year back.
What do you mean about a year back? Are you referring to the date of the incident of the murder?
No, sir. I have been treating him for the last 1 year.
Last one. As of date?
Yes.
When did he commit the offence of murder? I mean, that's the allegation. He is arrested now.
Yes.
You have any idea? Maybe around 2 to 3 months back.
2 to 3 months. It is.
It is not comparable to ordinary stress or mild anxiety disorders.
Correct.
In several cases, it can affect impulse control and judgment.
At at times it can.
I may be permitted to argue the matter and submit my.
Mr. Prosecutor, as you are aware, because of the recent guidelines laid down by the Supreme Court, insofar as submission of written arguments and oral arguments, you should not stretch to lengthy arguments, but you must precisely present your argument.
Judicial interpretation about the unsoundness of mind is not from Supreme Court of India. No, it is from High Court. I would want to emphasize this aspect. The judgment was delivered in the year 1969, Allahabad High Court.
A reasonable doubt, my lord. There is a settled law and a judgment which says in the cases where we are invoking such general defense like insanity or unsoundness of mind, we have to not prove it. We do not have to disprove anything, but we have to prove it. We have to prove that there is reasonable amount of doubt.
Which means not merely knowing is different from not having capacity to know. Section 84 or section 22 is attracted only when this particular proof is made. To this effect, there is one more important. Section 105 of Indian Evidence Act is a comparable provision is section 108 of Bharatiya Sakshi Adhinayam 2023. The accused on the day of murder or even previous day or previous week, where is the evidence? Second, the most significant. Again I am shocked. You are saying that he could have, even if Dr. Arun Mehta says he could have, that is not attracted by at the time of doing it. He must
Judgment of this court that on perusal of materials on record, oral and documentary evidence and circumstantial evidence, this court is of the opinion that the accused cannot avail the defense of insanity as defined under section 22 of the BNS 2023. The expert evidence of Dr. Arun Mehta has not inspired this court, as the doctor had not examined the accused any time before or immediately after the incident has taken place.
Mehta has convinced the court that he had incapacity. He may have depression, but he never shown that he had incapacity. In view of this, I conclude my arguments.
That he is legally insane, then we may, subject to the report of the experts, we may reconsider at an appropriate time.
Many fetal abnormalities in the first pregnancy as well. She gave birth to a handicapped kid, so she was keeping a lot of interest and care with the second pregnancy, and she went through timely and as per the doctor's prescriptions, she has taken all the medications, she has underwent all the timely scans that were mentioned and given by the doctor. She was getting her treatment done with a renowned gynecologist. After doing all the necessary and the required things,
We filed an application to cross-examine the company, for which they have filed objections. And today it is hearing on it. if you permit me, I just would like to
Please.
submit. When they filed their objections, the complainant sought the shelter under National Commission judgment, Srimati Indrani Bhattacharjee versus CMO, Prakka, Super Thermal Power and others.
Son, who was 16 years old, he was subjected to a minor surgery for the excision of a benign cyst. And prior to the surgery, he was subjected to various tests, blood tests and other ECG, chest X-ray and various other relevant examinations.
Without demeaning or without being judgmental, I want to make one observation. Last 2 to 3 decades, whenever there is an issue of informed consent, the same thing I was hearing. No, we sign without knowing, we sign without, there is no information, etc.
Therefore, at that stage of affairs, the case has been posted for arguments, and today I am presenting my arguments in this case. After a detailed research, I have drafted the complaint and I have made certain allegations against the complaint. Your Honor, I am representing the complainant in this matter.
And the skull is saying, deceleration started as they have used exterior and accordingly the baby was born. After 1 week, she has developed a pain in the knees. She couldn't either squat or sit or stand or even feed the baby. She came down. The doctor prescribed some medicine, but at the same time, it so happened, you will be surprised to know, Your Lordship, the doctor has referred her to Nimhan's doctor. They conducted all the tests and they said she is suffering from MS, multiple sclerosis. Then they filed a case against the doctor, etc. The issue is whether external forces leading to multiple sclerosis, not of the baby, but of the mother.
ಕ್ಲೋಸ್ ಮಾಡ್ತೀನಿ.
Certificate define key terms used in this document. Successfully fill the medical certification of cause of death by using different case scenarios. At the end we'll discuss about some case scenarios with example. Medical certification of cause of death. So what is a cause of death? All of us know, okay, why, by what cause a person would have died. So by definition, all the diseases or morbid conditions or injuries which either resulted in or contributed to death. Require data, they obtain data based on what MCCD we give to the Registrar of Birth and Death. Accurate cause of death data is essential for public health planning and surveillance system, for disease surveillance system as well as government public planning system requires the mortality data of a particular population. Of regional disparities are there regarding writing this certification, and also data quality issues. The quality of certification, they formulate a statistics like this. They know what is the major cause of death, mortality statistics. So you can see disease of the circulatory system, get a autopsy done. Only they can issue the autopsy surgeon will be issuing cause of death. So if manner of death is due to any external factors, unnatural deaths, MCCD should not be issued. Okay, it has to be kept pending for autopsy, post-mortem examination, pending for investigations.
Notification that all deaths should be that.
Doctor firstly or repeatedly
Certifications. Yes, you can write the columns in possible. Getting the the postmortem conducting doctor himself has to issue postmortem. Now they are asking for registration purpose and all, cause of death certificate from the. So whenever you use abbreviations, handwriting should be legible. Otherwise the purpose is not served. This scene, if the case is lost seen by the intensive we can. But in case of medical college, where we have a unit system, HOD and all, who has to issue the cause at MCCD?
Department only. So what we can do is probably this is one kind of this thing we can have one same thing involving all the departments. We can have one meeting. What do you say, sir? Because most of them are kind of incomplete, and government is very much strict with respect to all those registrations. MRD will be communicated to register and all those things. So instead of we kind of doing the repeated mistakes, we can have kind of similar things in our hospital involving all the departments, and we can take all those statistics department wise and we can correct there and then and there itself. Probably over a period of time we can improve ourselves so that not even a single mistakes will be happening for with respect to those.
Yes, sir.
When we asked what was the cause of death, they said cardiac arrest. Right? You know, I also die of cardiac arrest.
Yes, from this CME onwards we have to take in.
So basically no, BLS is very important. Basic life support training is very important for common population, helping in saving lives.
ತಗೊಂಡಿರೋ ಟಾಪಿಕ್ ಬೇಸಿಕ್ ಲೈಫ್ ಸಪೋರ್ಟ್. ಸೊ ನಿಮ್ಮ ಕಣ್ಮುಂದೆ ಯಾರಾದರೂ ಅನ್ಕಾನ್ಶಿಯಸ್ ಅಥವಾ ಅನ್ರೆಸ್ಪಾನ್ಸಿವ್ ಆದಾಗ ನೀವು ಏನು ಮಾಡಬೇಕು ಅಂತ ಫ್ಯೂ ಬೇಸಿಕ್ ಸ್ಟೆಪ್ಸ್ ನಿಮಗೆಲ್ಲ ನಾವು ಹೇಳ್ಕೊಡ್ತೀವಿ ಇವಾಗ. ಸೊ BLS ಅಲ್ಲಿ ಮುಂಚೆ ನಾವು ABC ಅಂತ ಹೇಳ್ತಾ ಇದ್ವಿ, ಏರ್ವೇ ಬ್ರೀತಿಂಗ್ ಸರ್ಕ್ಯುಲೇಷನ್ ಅಂತ. ಸೊ ಇವಾಗ ಲಾಸ್ಟ್ ಫ್ಯೂ ಇಯರ್ಸ್ ಇಂದ ಗೈಡ್ಲೈನ್ಸ್ ಹ್ಯಾವ್ ಚೇಂಜ್. ಇಟ್ ಈಸ್ CAB, ಸರ್ಕ್ಯುಲೇಷನ್ ಫಸ್ಟ್, ಏರ್ವೇ ನೆಕ್ಸ್ಟ್, ಫಾಲೋಡ್ ಬೈ ಬ್ರೀತಿಂಗ್. ಸೊ ಸರ್ಕ್ಯುಲೇಷನ್ ಅಂತ ಬಂದಾಗ ನೆಕ್ಸ್ಟ್ ಸ್ಲೈಡ್. ಸೊ ದಿಸ್ ಇಸ್ ದ ಅಲ್ಗಾರಿದಮ್. ಸೊ ಫಸ್ಟ್ ನೀವು ನೋಡ್ಬೋದು ವೆರಿಫೈ ಸೀನ್ ಸೇಫ್ಟಿ ಅಂತ. So we'll take only 5 minutes, then we'll divide the team and then we'll go for the hands-on. So first step is verify scene safety. So scene safe ಅಂದ್ರೆ ಅರ್ಥ ಏನು? So example ಇವಾಗ ನಿಮ್ಮ ಕಣ್ಣು ಮುಂದೆ ಯಾರಾದರೂ ಅನ್ಕಾನ್ಶಿಯಸ್ ಆಗಿ ಬೀಳ್ತಾರೆ, ಅದು ರೋಡಲ್ಲಿ ಇರ್ಬೋದು, ಇವಾಗ ಕೂತು ಚೇರಲ್ಲಿ ಇರ್ಬೋದು, ಸ್ಟೆಪ್ಸ್ ಮೇಲೆ ಇರ್ಬೋದು, ಯಾವುದಾದ್ರೂ ಸ್ವಿಮ್ಮಿಂಗ್ ಪೂಲ್ ಹತ್ರ ಇರ್ಬೋದು, ಎಲ್ಲಾದ್ರೂ ಇರ್ಬೋದು. ಸೊ ಫಸ್ಟ್ ನೀವು ಸೇಫ್ ಇರಬೇಕು, ಪ್ಲಸ್ ಪೇಷಂಟ್ ನ ಅಥವಾ ವಿಕ್ಟಿಮ್ ನ ನಾವು ಸೇಫ್ ಜಾಗ ಕರ್ಕೊಂಡ್ ಬರ್ಬೇಕು. ಸೊ ದಟ್ ಈಸ್ ದ ಫಸ್ಟ್ ಸ್ಟೆಪ್, ದಟ್ ಈಸ್ ವೆರಿಫೈ ಸೀನ್ ಸೇಫ್ಟಿ. ಸೊ ಅದಾದ್ಮೇಲೆ ಏನ್ ಮಾಡ್ಬೇಕು ನಾವು? ಚೆಕ್ ಫಾರ್ ರೆಸ್ಪಾನ್ಸ್. ಪೇಷಂಟ್ ಕಾನ್ಶಿಯಸ್ ಇದಾರೆ ಇಲ್ಲ ಅಥವಾ ಪೇಷಂಟ್ ರೆಸ್ಪಾಂಡ್ ಮಾಡ್ತಿದಾರ ಅಂತ ಚೆಕ್ ಮಾಡ್ಬೇಕು. ಜನರಲಿ ನಾವು ಪೇಷಂಟ್ ಶೋಲ್ಡರ್ ಮೇಲೆ ಟ್ಯಾಪ್ ಮಾಡಿ ಅವ್ರ ಹೆಸರು ಗೊತ್ತಿದ್ರೆ ಹೆಸರು ಕರಿತೀವಿ, ಇಲ್ಲ ಸರ್ ಅಥವಾ ಮೇಡಮ್ ಅಂತ ಕರಿತೀವಿ.
Shivkumar BB and team kindly receive a token of appreciation. We'll be heading towards the next building to perform the hands-on workshop. The second, congratulations winners, and the third prize goes to Dr. Pawan B and Dr. Sanjeev DK. Congratulations to the winners. The hotel.
ನಾನೊಂದು ಡೆಮೋ ತೋರಿಸ್ತೀನಿ, ಅದಾದ್ಮೇಲೆ ನೀವೆಲ್ಲ ಬೇಸಿಕಲಿ ನಾವು ಏನು ಮಾಡ್ತೀವಿ, ಕಾರ್ಡಿಯಾಕ್ ಅರೆಸ್ಟ್ ಫಸ್ಟ್ ಏಡ್ ಅದಕ್ಕೆ ಕಾರ್ಡಿಯಾಕ್ ಅರೆಸ್ಟ್ ಎರಡು ಒಂದೇ ಅಲ್ವಾ? ಗೊತ್ತಿತ್ತು ಒಂದು ಕೊಟ್ಟಿದ್ದಾರೆ. ನೋ, ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್ ಅಂದರೆ ಕಾರ್ಡಿಯಾಕ್ ಅರೆಸ್ಟ್ ಅಂದರೆ ತುಂಬ ವ್ಯತ್ಯಾಸ ಇದೆ. ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್ ಅಂದರೆ ಹಾರ್ಟಲ್ಲಿ ಒಂದು ವಾಲ್ವ್ ಬ್ಲಾಕ್ ಆಗಿರುತ್ತೆ. ಅವಾಗ ಏನು ಮಾಡ್ತಾರೆ, ಕ್ಯಾತ್ ಲ್ಯಾಬ್ ಕರ್ಕೊಂಡೋಗಿ ಸ್ಟಕ್ ಆಗ್ತದೆ. ECG ಮಾಡಿದ್ರೆ ಹಾರ್ಟಲ್ಲಿ ಬ್ಲಾಕ್ ಆಗಿದೆಯಾ ಇಲ್ವಾ ಗೊತ್ತಾಗುತ್ತೆ. ಅವಾಗ ಆ್ಯಂಜಿಯೋ ಮಾಡ್ತಾರೆ, ಆ್ಯಂಜಿಯೋಗ್ರಾಮ್ ಮಾಡಿ ಒಂದು ಬ್ಲಾಕ್ ಇರುತ್ತೆ, ಆ ಬ್ಲಾಕ್ನ ತೆಗೆದು ಸ್ಟಂಟ್ ಆಗ್ತಾರೆ, ಅದು ಹಾರ್ಟ್ ಅಟ್ಯಾಕ್. ಓಕೆ,
ಆದಾಗ ಪೇಷಂಟ್ ನಾವು ಹೇಗೆ
ಹೇಗೆ ಅಸೆಸ್ ಮಾಡಬೇಕು, ಅವರಿಗೆ ಸಿ ಪಿ ಆರ್ ನೆಸೆಸಿಟಿ ಇದೆಯಾ, ಹೇಗೆ ಇದನ್ನು ರೆಕಗ್ನೈಸ್ ಮಾಡಿ ನಾವು ಎಷ್ಟು ಬೇಗ ಆ್ಯಕ್ಟ್ ಮಾಡ್ತೀವಿ ಅನ್ನೋದು ಇಂಪಾರ್ಟೆಂಟ್ ಆಗುತ್ತೆ. ಸೊ ನಾವು
I think it's going to be more easier. So I think, have you guys done anything about BLS? Have you all attended any session of BLS? You guys have? Yeah. So apart from BLS today, if you guys want, because you all are from the medical ground, I can even teach you about ACLS, not a problem. So I think cardiac arrest scenarios can happen anywhere, right? It can be in the OT, it can be in the labs, it can be in the classroom, whatever said and done. When do you say there is a cardiac arrest? What do you feel? What do you feel categorizes as a cardiac arrest? On the road, wherever. Now, what is the first step in case life skills? What is the first thing? If you see, you've gone out for shopping or you've gone out somewhere, and first you need to verify the scene safety. Okay, how do you verify the scene safety in a road traffic accident? What do you do in a road traffic accident? Because Madhyadalli, there is the patient is in the middle of the road. What is the first thing you're going to do? Yeah, keep the patient aside. I mean, put the victim to the side of the road. Okay?
Emergency number is generally called 108. Both will go to the center, which again diverts the calls to the respective areas.
ಏನೋ ಒಂದು ತೊಂದರೆ ಆಗಿದೆ, ಇಮಿಡಿಯೇಟ್ ಆಗಿ ಯಾರು ಮಾಡಿದ್ದೇವರು 108 ಅಥವಾ 112 ಇದೆ, 108 ಇದೆ, 108ಗೆ ಕಾಲ್ ಮಾಡ್ಬೋದು. ಇಲ್ಲ ಲೋಕಲ್ ಆಂಬುಲೆನ್ಸ್ ಏನಾದ್ರು ನಂಬರ್ ಗೊತ್ತಿದ್ರೆ ಮಾಡ್ಬೋದು. ನಿಮ್ಮ ವೆಹಿಕಲಲ್ಲಿ ಅಂತೂ ಕರ್ಕೊಂಡು ಹೋಗ್ಬೇಡಿ. ಯಾವ ಲೋಕಲ್ ಆಂಬುಲೆನ್ಸ್ ಲೋಕಲಲ್ಲಿ ಕರ್ಕೊಂಡು ಹೋಗಿ ಆಂಬುಲೆನ್ಸ್ ಇದರಿಂದನೇ ನಾವು ಕನ್ಫರ್ಮ್ ಮಾಡಬೇಕಾ ಕಾರ್ಡಿಯಾಕ್ ಅರೆಸ್ಟ್ ಆಗಿದೆಯಾ ಇಲ್ಲ. ಓಕೆ, ಎಷ್ಟು ಚೆಕ್ ಮಾಡ್ತೀವಿ? 5 ರಿಂದ 10 ಸೆಕೆಂಡ್ಗಿಂತ ಜಾಸ್ತಿ ಇಲ್ಲ. ಪೇಷಂಟ್ನ ಮತ್ತೆ ಎಚ್ಚರ ಮಾಡ್ತೀವಿ. ಪಲ್ಸ್ ಇಲ್ಲ ಅಂದರೆ ಪಲ್ಸ್ ಚೆಕ್ ಮಾಡೋವಾಗಲೇ ನೀವು ಉಸಿರಾಟನ ಯೂಶಲಿ ಚೆಕ್ ಮಾಡ್ಕೊಂಡ್ರೆ ಜಸ್ಟ್ ಮೂವ್ಮೆಂಟ್, ಜಸ್ಟ್ ಮೂವ್ ಆಗ್ತಿರೋದ್ರೆ ಯಾರು ಉಸಿರಾಡಿದ್ರೆ.
This is not CPR. You need to keep the elbow straight and your pressure should come from the shoulder, right? So, this is not like good quality CPR. But if you do something like this, then what will happen is, as you give CPR, your hand position will move. At one point, you will be giving CPR near the abdomen. We have seen that. Very common mistakes. But this is something, because you are from the medical fraternity, I am just emphasizing. Okay. So good quality. Okay. Now you know the qualities. What are good quality CPR? What are good quality CPR? Rate 100 to 120 per minute. Right. Next step. Next. What ratio?
These are the methods of giving breathing. So since you all working with the ambulance, access to the ambulance will teach you. So the mask should be adequately fitting. What is adequately fitting mask? When you keep it on the nose of the bridge of the nose. Do not touch the patient. That time we should stop the CPR. These are some of the types. What are the types? Shocking, non-shocking.